Afternoon, everybody. Let's call it to order. It is 2 p.m. on September the 14th, Kern Valley Healthcare District Board of Directors meeting. Okay, first item B, approval of agenda. We have flag salute by Mr. Elliott and invocation by Mr. Gordon. I'd like to start with those.
Hey, please join me in saluting the flag of our great nation. Salute, pledge.
I pledge allegiance
to
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Bow your heads with me, please. Heavenly Father, we're just so grateful that we get to come before you this afternoon to better the Kern Valley Healthcare District and make decisions that are guided by these individuals present in the room. We are grateful that you give us the day-to-day resources to provide this service in our community. We ask that you continue to do that on a daily basis in Jesus' name.
Amen. Amen. Public comments for anything not hearing. Sorry,
Agenda, you were gonna take off that one, did we get there?
we will. We'll do that next. Yes, sir.
I'm standing for public comments.
Yes, ma'am.
Hello, my name is Diane Bolcom. Some of you know me. I am still an employee here, but I'm retired. And so now that I'm retired, I have time to come to board meetings. So I hope you'll see me occasionally. So that's my public comment, but as an employee, I want to thank the board for that lovely check that you all provided us. And I'm not sure that you get to hear that very often, but thank you so much for making that available to us. It was a great surprise. And I know that myself and many of my colleagues really appreciated it. Thank you.
Thank you, Diane. Fantastic.
You all deserve it.
Any other comments? Okay. Seeing nothing, moving on to consent.
So I think, correct me if I'm wrong, Scott, because we're pulling G1, do we need to approve the agenda of striking that off
Yes,
the agenda?
what we're doing.
But that's not consent. That's
When we get there, we can just table it.
okay. Oh, okay.
Yeah.
Okay.
Mr. Elliott, you had an item you want to remove from consent?
Yeah, I would like to discuss item number 12, the ER barcode scanner.
Which, what that move to
New business.
new business? Or old business, new business. You want to make it item 5?
That's fine with me.
Okay. Any other changes to consent that anyone has seen they'd like removed or discussed? Seeing none, a motion to accept the changes.
So moved.
Second,
I'll second.
okay. All in favor?
Aye.
Aye, okay, thank you. Right. Oh, forgive me. Okay. Go to reports. Yes, S?
Ready?
Yes, ma'am.
Good afternoon. I'll go ahead and do the foundation first. Obviously, I'm busy up to my elbows in Crowd Fest. I can't wait for Saturday to be over. I think we have a lot of really nice silent auction items. Of course, we have the trip to Mexico, but we also have a 2-night stay over at Oceano, which is, I guess, by Pismo Beach. And we have a bottle of wine that was worth $100.
Cool.
So we have some really good things. So I'm looking forward to those of you that's going to participate. And then the auxiliary, we made just a little over $9,000 last month, and we're playing along. They're doing a summer bag sale right now to kind of move out some summer months. Questions?
How did the River Rhythms do this year?
Okay, we did well, considering that we held it at the Circle Park. I haven't had Orion send out a survey yet, but we want to do a survey to find out if the community prefers it at Circle Park versus having it at Riverside. The one great thing is that there's that stage there, so we don't have to have the manpower to set that up. The money that we collected was just over $3,000, which was decent. And so we'll be able to give out $3,000 worth of scholarships for 2021.
I think some of the things that we potentially lost was there are a lot of folks that were staying in the restaurants
Yes.
and listening from there, so they didn't get the opportunity to donate, you know, when we passed the thing around and stuff like that, so.
Can you just make the circle a little wider and pick them up?
We thought about closing that
Yeah.
one street off, but that was a last minute thing, and there's a lot of hoops we have to jump
Yeah,
through.
just from access.
Okay.
We are gonna have Angels Bruce back for next year, so they'll be the last band. And I don't know if any of you went to the ceviche. No, not the ceviche, where was it? Highway 178. They had a Zeppelin band there, and so we've been talking with them, and they might be the first band. So. Right.
When I heard they are, no.
They're very good. They're very good. So that's my report.
Thank you.
Ross.
Thanks.
Medical staff report, Dr. Festa?
Me.
That's you?
Apparently.
Okay.
The medical staff for ED committee met on August 22nd. They discussed ultrasound guided regional anesthesia program, progress on our sepsis program. Committee discussed additional tests for pneumonia with antimicrobial stewardship in mind. Primarily urine strep pneumonias, Legionella, MRSA, NARS testing and so forth. They also discussed prospective addition of barcode scanning to the ED, which we're going to probably talk about a little later. The committee reviewed regular reports, for statistical blood culture analysis and so forth. On August 22nd, also, we had the medical executive committee. Committee reviewed and approved one credential file for Greg Davis. The committee also reviewed and approved 4 policies. Abuse prevention program and reporting policies, trauma-informed care for all nursing staff, skilled nursing staff, and alcohol withdrawal assessments. One policy is still in process, which was wound documentation. Committee also reviewed and approved the SNF e-kit list, emergency kit, and inventory forms, and the FDA pain control notice for basic clinical. They also reviewed and approved 2 additions of cyclobenzaprine and carbamide peroxide to the formulary, and also reviewed normal regular reports. On August 24th, Utilization Review Committee discussed charge recovery and new swing bed process. The committee discussed some new requirements, which will be screening for social drivers of health. And the committee reviewed regular reporting. August 29th, Medical Quality Council, board members were given updates on regular reports, risk summary for the first and second quarter, SNF QA studies for the first and second quarter, MD Clip, and then MPSG department QR reports, SNF plan of correction updates, antibiotic stewardship committee minutes, and so on. On September 13th, the P&T committee met. Discussed COVID-19 preparations, their old business, reviewed and approved 10 policies, and also retired 2 policies. The committee reviewed and approved a T system order revision. Committee reviewed and approved in addition to the formulary for methazine. Committee reviewed and approved changes to SNF e-kit and associated documents, and also the regular reports. And that is the medical staff's report.
Questions for Tim regarding Gary's report?
I don't have any questions.
Okay.
I'm sure I could answer.
Thank you, Doc.
Hopefully I could.
I just,
In that case,
you can pay me later for saving your.
Chief Executive, sir.
First of all, good to be back. Like physically, I'm feeling good, just still a little working on my strength to the point in time to get my the word I'm looking for, stamina. Thank you. That's exactly the word I'm looking for. But anyway, doing great and glad to be back. Just a couple things that I had that I want to bring your attention. We received notice from the Cattle Hospital Compare program. As you know, there's a national hospital compare program that looks at both scores for hospitals and also for skilled nursing. This is the state's version of that. we were informed that for 2023 that we were awarded their patient safety honor roll. And 82 hospitals out of 347 hospitals that were considered for the honor roll were awarded, which represented only about 24% of the total hospitals. So it's a pretty big honor and very difficult. There's a lot of algorithms and so forth to go into the calculations of how they figure patient safety and so forth. And so, you know, we shared with the staff in our manager's meeting the other day. I want to do something hospital-wide for the staff because this is something I'd been hoping for since I came. I want to see some kind of a major recognition for the quality work that they do, and we got it. So, you know, this is, I think, a great place to start. Again, I thank Dina for all the work that she does that kind of goes unseen at times, you know, and gathering and prodding people to do the data reviews and make sure stuff happens and so forth. But as she said in one of our meetings of the day, it's really the people on the ground that are the ones that are actually doing stuff, and it shows. And this is something, like I said, that we want the community to know, and I think Deb has been communicating that out to the newspapers and so forth. It's a big deal, you know, and I have a list of hospitals that made that, and it's the only other hospital in Kern County that made it was Adventist Health Bakersfield. Just some major medical centers on here. And so it's just kind of great to see our name. It's back in the middle of it, right under Keck Hospital, USC, and Loma Linda University. We were right up between the two of them. So just something to be proud of. You know, again, that we're confirmation that we're doing things right, you know, for the community. And so that was great. The next thing I want to do is give you an update on there was a conference call with the hospitals the other day. KVHD Board had a board meeting Saturday morning at 8 o'clock, which was a negotiation session with the legislature on this SB 525, which was the new minimum wage law. The proposal was to require hospitals to go to a $21 per hour minimum wage effective June 1st of 24, which is the last month of our fiscal year this year. And then to $25 the year after that. And so they were announcing that they were successful in negotiating a deal between all the parties, between the legislature, the unions, and everyone else. That basically broke the hospitals down. And this is not just hospitals, but it's clinics and all healthcare providers into three baskets. The first basket was the major medical centers. There was 12 major medical centers with more than 10,000 full-time equivalents, and they will start at $23 an hour in this June, go to $24 next year, and then $25 the year after that. And then thereafter would be index based on the lower of inflation, or 3.5%. The next category of hospitals was what they considered California's most vulnerable communities served. And one was the 31 hospitals in the state that are not part of the health system and are rural. The 39 hospitals in the state that are not part of the health system that have a government payer mix of 75% or more. And then the last was 7 hospitals in the state that are part of the health system, that have government mix of over 90%. We will start, if approved, on June 1st of 24 at $18 an hour. And then thereafter, it will be an automatic annual 3.5% increase to the minimum wage every year until you hit $25. So that won't happen until 2034. So it'll take 10 years to get to that point. So they figured that was an adequate rollout, but considering that your minimum wage right now is $15.50 and now you're bumping that to 18, that's a $2 an hour, $2.50 an hour increase, which is significant. So, you know, obviously it's going to create some compression issues. So we're going to talk administratively, you know, can we do this? You know, how would we do this? you obviously can't take, because this represents a 16.1% increase over our current minimum wage. You can't just bump everybody up 16%, so we're not attempting to try and do that. So we will have some compression, but most of that compression will be at the upper pay levels, and so forth. So, and we'll bring that back to you. We'll just discuss that.
Tim, how does Ridgecrest fall into this?
They would be in that same mix because they're considered a critical access.
So we won't have adverse selection to it.
We should, but where we will have some, okay, potentially, if this happens, is the fact that the 2 of the 12 major facilities that are in that first group that start at $23 an hour, it's Dignity and Adventist Health. So there will be some possible issues there where some staff may decide I want to run down there. We've talked about it ourselves, and I think we've had some staff that have left for more money down there only to come back 6 months, a year later, saying it wasn't worth it.
Close for a couple of years.
Well, the commute will eat that up if they
Well, I
continue
think
to live.
that's kind of the issue here.
$5 a gallon.
And then all other hospitals in the state, and this would be inclusive of the FQHCs like Clinica and Omni and stuff like that, they'll start June 1st of 24 at $21 an hour. And then it stays at 21 for 2025, jumps to 23 for the next 2 years, and then in 2028 it goes to 25. Now this agreement also creates an issue with contractors. They said contractors for whom the hospital has joint employment liability, those contractors for whom the hospital determines their wages, hours, and working conditions. We don't really have any of that, to my knowledge. The other one was for contractors who work primarily 51% of their time on hospital premises. So that's
Ultrasound, please contact the ER.
so
Ultrasound,
most
please
likely
dial
is,
251.
that I can think of. So they would have to apply to these same pay rates and so forth. Now, on a conference call last night with the CEOs, there was an update from the hospital council that shared with us that the one big issue that might be a whole question in this thing right now is the fact that both the Assembly and the House or Senate are voting on this tonight. It has to be done by midnight. That's the end of the legislative session. It is expected to pass both of those houses. What we heard last night for the first time was that there's some questions as to whether the governor will sign it, primarily because this impacts state hospitals, which would be a $4 billion increase to the state payroll if they do this. So there may be pushback at that. Well, not so good, because then the union's plan is to go to a statewide ballot initiative, $25 for everybody. So, that would hopefully be a difficult sell for everybody, but they're willing to put obviously big bucks into that and stuff like that. So,
Was there any talk of reimbursement as part of their negotiation? Who's paying for this? Yeah, this is stupid.
of course, and they said, well, this is why we like, especially with the vulnerable hospitals like us. So this is why we have a 10-year rollout. So you guys can figure out how you're going to adjust. I'm going to
Oh, yeah, we'll raise our rate.
Yes.
We have
So-
10 years to close the door.
Who knows? So anyway, it's we'll see what happens. I'll keep you apprised. I'm sure we'll hear something tonight. Don't know how quickly it'll end up on the governor's desk if it is approved, or what that'll mean beyond that. But we've started having some conversations here administratively about what does this mean for us? What would it look like? And so what we'll do, we'll bring it back to the committees and we'll, board committees, and we'll share all that with you and let you help with that process. We've been working with Anthem Blue Cross. They've finally reached out, they've got their thing together. They're going to be replacing HealthNet as the commercial Medi-Cal managed care provider here in the state. And so we're now going through that contracting process to make sure that we've got the rates in place and that we've got, our providers credentialed and all those kind of things. Shouldn't be a huge problem. And so forth, but that's just getting underway. So if they have that, if they take over effective January 1st of this year.
Can we negotiate that at a $25 per hour rate?
Yep, somehow I'm not so sure. I thought though. Also at our CEO conference call last night, there was some discussion about, an update on COVID. None of us really want to talk about it right now. I think the good news coming out of the county public health department is the fact that our COVID admissions are extremely low. It's like 4 per 100,000 admissions. Much lower than the area, much lower than Fresno and some of the other counties around. I think there's 25 people hospitalized throughout the county. And a number of them are probably have other issues going on, just happen to have COVID as well. The other good news is they said RSV and flu are also remaining very low numbers at this point in time. So hopefully that's a good thing. The flu, there was quite a bit of conversation last night. One of the things that the county public health officer did was he mandated for our employees that if you don't get the flu shot, you have to wear a mask anytime you're in the hospital throughout the entire flu season. And so it was put to us last night as to whether or not we wanted them to change that from a mandate to a recommendation. I supported the recommendation. I think each facility should be able to decide for itself based upon the positivity rates that they're seeing in their communities as to whether or not we want to mandate our employees need to wear masking or whatever. I try to jump on those first to get my thoughts out there before anybody else does. Everybody else agreed with that and just said the system CEOs basically says, well, we have to kind of wait what comes down from our corporate offices and whether they're going to make us do it or not. But everybody else said, no, we agree for everybody else's sake, which should be recommended, not mandatory. So that is the way the county is, Bryn's going to present that to the board of supervisors. So, and to the public health officer. So we'll see whether or not there's a change on that. Let me see. The Met team, it was announced that there is an RFP that's being sent out to hire a Met team for Eastern Kern County. And also the fact that if hospitals had psychiatric beds, that they were going to begin hiring hospital teams so that those facilities with beds could write their own 5150s. And so the Med team for Eastern would be for us and for Ridgecrest and one other area. So we would share a team that would come out to do our 5150s for us.
California City.
Yeah, I think it was California City. And so that RFP has already been released apparently, and so they are interviewing and stuff like that. The other thing
That solve anything? With no beds.
What? I'll let Mark address that.
All right.
I think it'll make a difference. At least we have a team in place.
Yeah.
So as we can get other things to change and beds come available, we'll be able to place them quicker than we do now.
Right.
So, I mean, I think eventually it will make a big difference.
It could.
At least somebody else besides just us will be
Right.
involved in it.
Right.
Which, is
Can make a
a second
Yeah, 'cause
place
once
makes
they
a difference.
Once they write that order, then obviously they've got to be transferred to an appropriate facility. So that's the importance of getting
And they're the ones that help do that.
correct.
So it takes time away, that we're not the ones sitting and working on it the whole time.
Yeah.
They're also helping work on it.
Exactly. And that led to our next conversation, which is in the last week and a half, we've had 4 conversations with Kern County hospitals that are basically telling us that they are refusing to accept ER to ER transfers. And I'm going like, what? I contacted the CEO directly the first time that happened. He is there. They have a regional transfer center that operates out of Sacramento. And I'm going like, how do you guys know what the hell's going on down here, you know, or what our situations are or whatever? They said, have no policies whatsoever to prevent that. So I said, but this is what your staff is communicating to my ER doctors who are trying to transfer critical patients. We had two more at two other facilities. So I announced this at the CEO conference last night, and one of the CEOs actually called me this morning. He said, was my hospital one of them? And I said it was. And so shared with him patient information, and he's going to go back and research what the heck was being said. He said, that is not our policy. And so forth. And the other one is I'm still reaching out to the CEO. But yeah, then we had communications with trying to get a patient into Heart Hospital. And they said, well, we're not going to talk to you about that anymore. So you got to call Adventist and go through their transfer center and so forth. So we're not going to take ER patients unless they approve them. So, yeah, so some of the practices have changed. The rules technically have not changed and so forth. So I kind of put them on notice that this is not acceptable, and all of them are kind of jumping through hoops and going like, because this could potentially EMTALA issue, you know, and so could be a big issue for them.
So a side note on the Heart Hospital.
Yeah.
The gal that told our ER tech that was wrong. And she called back and said, we will take your patient. So.
Because the sale hasn't gone through yet. How can they be running your transfers? So anyway, so it's just been a little strange the last couple of weeks, but you know, we jumped on that right away, and I think in all cases, I think but one, we did get the patient transferred out, and they're where they need to be. But it was interesting because it appears that instead of doing the ER to ER transfer, what they try to do is to avoid EMTALA. They said, no, we're trying to get you a bed in the hospital or in the ICU or whatever. Of course, but that means until they have a bed, then we've got to keep them instead of getting them into their ED. So it's a quick transfer up and so forth. So, but it takes.
But they want it to look like a direct admit, not.
Exactly.
Okay.
Exactly. And so that takes some EMTALA out of play and so forth. So just some games I think that are being played.
Which means then they insurance.
Right.
Right, because one of them actually admitted that they knew his patient's financial class was. We said, we don't communicate that information, but they were aware. I think that's exactly what it was, but that kind of probably made it more of an EMTALA issue because they were doing it for financial reasons. So, well, two other things. Current Health Systems Boards announced their big grant cycle, 2-year grant cycle. That was approved at the last board meeting. That's come out. Greg's already got things. He's working on some things for staffing that we're going to put into. There was some concern on some of the language that a lot of the staffing money was being sucked up by the quote unquote safety net hospitals. I've got to call in on that. I think we'll be able to do what we need to do in spite of that. And so, so we're going to go ahead and put it in. And so there's some other things. I've got a phone call later today with Good Sam Hospital to see, and also with Clinica to see if there's something we can do about behavioral health up here. Heart Hospital's got a number of psychiatric providers that they're willing to bring into play and help with community service up here. We might need help providing sites, and maybe this is something we can use the building across the street for, and so forth, which we desperately need in the community. So, and then get grant money from Current Health Systems to pay for that. So that's one of the things we're trying to work on. Then we're going to look at a couple of things. The last thing I wanted to just talk about quick was I got about 166 page bulletin from the feds. Apparently, the administration has decided that they want to mandate mandatory staffing ratios or standards for skilled nursing facilities nationwide. And so that are probably, they're one of the minimums was that they want an RN in-house 24/7. Good luck with that. I mean, right now, it's only required to have an RN 8 hours a day. And so this, when they admitted that there is a shortage of RNs and nursing assistants, but yet you want to increase the standard threefold over what it currently is. And their rationale is that this is obviously proved through some recent study they just had done. And obviously that more staff means better quality. And in some cases, yeah, I would agree with that, but not necessarily. It's got to be the right staff and doing the right things. So again, and then the RN, the 24/7 RN was a minimum. You had to have it. Then beyond that, there is a standard for hours per patient day, RN patient per day, which is higher than we've got. Then also an RN, a staffing ratio per resident day for the nursing assistants and so forth. And right now we're just shy of that one. RN one would be an issue, but it would require significantly more RNs. But we also have an LVN ratio, which doesn't consider into those numbers, which puts us over the top on these things here. But yeah, the big issue for us is obviously that 24/7 RN. It's hard enough just getting an RN here 7 days a week, which is one of the issues we have for the star rating system and all that stuff, which we've done. And so anyway, they're pushing this through. This is a mandate that he did 2 years ago that he has now pushed through the standards. And so it's in public comment period. I think they've got until November 30th or something to get comments back on it. But they're going to move. The sense is they're going to move forward with this. So, you know, there's been a lot of pushback from some of the other agencies because, okay, great, so you're going to mandate this. You're not going to provide any money for it again. And you're going to compound a staffing shortage that already exists on the acute care side, as well as the skilled nursing side. So what's the point? I mean, just to say you did something. So not sure what's going to happen with this, or whether or not there'll be any substantial changes or not. But that's just something that's going on. So we're assessing, like I said, this monster packet is the, you know.
Well, who's lobbying for something like that?
This is something the Biden-Harris administration decided they wanted to do. It was funny because they said there was some.
It's gotta be the unions.
I think so.
Gotta be driven by
They
the
said
nursing union.
there was some study that they had done and they didn't cite the study. And I'm going, and they said, and then they admittedly said that it was, yeah, probably groups of people. They say they had 3,000 comments from the public, which they admittedly said most likely were people that were supportive of putting more people in the hospitals. And they're going like, so where's the actual quality clinical data?
Do the RNs have to be awake?
Yeah, I was gonna say, use an emergency room.
Well, it's interesting is that they had to be on
They're
site.
sleeping all the time.
On site, there you go.
Yeah,
That's
So-
what seems, because of the shortage, I mean, it doesn't make,
I know.
There you go, it's offered free
there's
lodging,
no legal.
free lodging here
logical-
for an RN.
That's right.
But it also could be, from my Washington experience, the RN academics very much push that 1-to-1 RN ratio.
Yes.
So some of that data that they come out and cite is based on the RN studies
Yes.
that frankly are supporting their RN program.
Right.
So it's quite it's a.
Self-serving in some respects.
It feels self-serving.
Could it have anything to do with Biden's age? Is he feel like he'll be much better care?
A lot of things seem to be attributed to his age recently. So I'm just reporting this is what's happening. So, like I said, obviously we'll keep you all apprised of these as we learn more and as things change, which hopefully they will. And go forward. That's wonderful.
Any additional questions? Tim? Catherine?
No, that's a lot,
Yeah,
thanks.
one question.
Yeah.
How's our FEMA grant coming?
At this point in time, like I said, from what I understand, we're in a good position. All of the projects that are still in the bucket appear to when you add up all of the costs from those projects, appear to fall within the range of the monies that have been
No,
set aside.
nothing new.
Nothing new yet. Like I said, there are, Bob and I've talked about some possible things that they might come back and just ask us for some updates on. One of which was the NEPA CEQA study. Remember, the last one we had done by Karen Northcutt was when we were proposing the building expansion that was gonna go across the street and close off the road and everything else. But, you know, we scaled that project back for cost issues. And so now we're operating still within the building. So worst case scenario, that was for a significant change external to the building. So being that we're not looking to impact any outside stuff, it shouldn't
be any impact.
shouldn't be any impact at all, you know, because it's existing. And so so we'll wait and see whether or not that's something that may come back and just ask about. But all appearance, it looks like we're in pretty good shape. So
Oh, thank you.
yes.
On your Cal Hospital Compare.
Yeah.
Presentation. We need to bring a lot of attention to that.
Yeah.
You know. An editorial to the newspaper, a banner across the front of the hospital.
I think it is.
You know, social media. Announcement at Crab Fest, announcement every time we get up and talk.
Yeah, this is big thing.
Fantastic.
It's a big thing.
And it's independent verification of the great job that's being done here.
Yep.
And we need to stand up and shout about that.
Yeah, especially within our so forth, because like I said, the staff are doing the work.
If we had access to a writer who could get this information out.
When did this report?
Just while I'm out on vacation, I was actually, I just happened to look out over to the hospital.
That's wonderful.
And,
news. Golly, that's great.
You know, and it's funny because like these things have come out for the 14 years I've been here, and we just keep saying, "Oh, God, it'd be great once to see our name on there." And so I'm flipping through the pages, and all of a sudden, my Kern Valley Healthcare District, they did the bell.
You know how high schools put up a banner across their gym when they're a state champion? We need to do the same thing.
Well, a lot of the hospitals down in Bakersfield put them up in the front of the hospital and stuff like that.
Let's do it.
Yeah.
Yeah.
We need to get that banner.
Yeah, I agree. Yeah, so we'll do that. Yep, that's important. It's a big thing. Big thing.
John?
Yeah, we can probably get you scheduled an exchange, but maybe do a presentation.
Yeah.
I was just hassling Mark. We found this badge. Everyone's back in the club.
I'm sure he's got some hefty fines going too, so it's the first chance.
We can arrange that.
Yeah.
Thing or two up his sleeve.
No, anyway, no, it was great news. It's just something I've wanted for so long for this hospital, and nice to see that come.
Tim,
Yes,
Kyle's gonna be calling you back on that.
great, good, happy to be with him.
Thank you.
You're welcome.
Mr. Gordon?
Nothing left badger, not my badge.
Oh, that's
You can
good.
arrange deeper.
Hey, so, yeah, this is, my September report. The COVID numbers, as Tim mentioned, in our own community here close to us. They jumped up a little bit in August to about 2.8% coming through the ER. But there were very few that were actually admitted. I think we only had 2 or 3 that were actually admitted. Everybody else that was positive went home. And there were somewhere between 7 and 9.
Were they admitted for COVID or were they admitted for other things?
They were admitted for other things and an incidental finding was COVID. So it was kind of interesting how that came out. But so we don't have a lot of very sick people, residents in the community that are suffering from COVID. And a lot of people may even have it, but they're just choosing not to get tested. And that's another part of it, that's another side of that.
Yeah, I'm glad you brought that up, because that was a comment that was made last night, with the fact that almost kind of looking to not look at the positivity rates for population anymore, because since so few people are getting tested. So it's like the numbers, you can't trust the numbers, you know, like we did when everybody was getting tested. So, yeah. Which makes it a little harder to really.
It does make it harder to track, but we can only track what we see.
Right.
So that's kind of the deal.
Good that you're doing that.
Transportation service has been providing multiple rides per day. Ross was good enough to share with me the grant cycle for current health systems. I'm gonna be looking at trying to get reimbursement costs for our drivers and for our fuel that we use. And hopefully they'll be able to do that. I don't think that will be very expensive on the grand scheme of things. That's one of those initiatives that they're really interested in, providing transportation for their members. And so I think that if I write it correctly, we can make sure that I'll write in a 3.5%. Or a 16.
It'd probably be the higher, and that's probably more for the gas increases than it is
Does,
increase.
part of that grant, does that do anything with like the maintenance on the vehicle itself?
No, it doesn't do.
Just for transportation, the
Just the
cost?
Transportation cost, yeah.
Their big issue is that they statewide continue to have issues with access for people to be able to get to the hospital. And so, and even though the health systems have significant requirements, they have to provide bus passes, they have to provide Uber and Lyft transportation, they have to pay people that want to go. Even if someone decides to drive themselves to their own doctor's appointment, they can then submit a bill to current health systems for the mileage and so forth, and they're required to pay that. And so that's the requirements the state has put on. So that's why the state's trying to see us develop these transportation programs to make sure, just because there is an absolute tie to quality, because again, patients aren't getting their doctor's appointments, they're not getting their meds filled because they can't get to the pharmacy or whatever it is. And it's even beyond just the normal things that you expect. I mean, for dentists and these kinds of things as well. And so it's getting that whole patient care thing. And so we've been encouraged to expand our program as much as we can. Obviously, they realize it's a big issue up here, people getting in because of our difficult environment up here. So
to answer your question, the maintenance of the vehicles is being absorbed out of my maintenance budget.
Yeah. And with it, hopefully it's not terrible numbers, so.
They're pretty new vehicles. Yeah, but you know, it's minor stuff. We did receive notice from the California Association of Health Facilities. They were offering grant funding for our nurse assistant training program. We were awarded we will be awarded $2,000 per successful graduate from our CNA program.
Wow.
So for every successful certificated CNA that we graduate, up to 24 per year, they'll pay us $2,000.
Wow.
Reimbursement fees. So that was a nice thing that Brandy found, or Julie found, for education. So that was really good. I signed a paperwork just 2 days ago. It's the California Association of Health Facilities. They call it the CNAP Earn and Learn program. So it's the Certified Nurse Assistant Program, Earn and Learn. The ones that we pay you to go to school, is that the ones you're talking about?
Yeah.
Let me get some of that back then.
And then the census in the ER continues to be over what the budgeted numbers are. So we're seeing a lot of, we're seeing days where there's excess of 30 patients every day. And these are numbers that we don't see very often here. So I think people are now coming back to the hospital. They're not afraid of COVID, but they're not getting tested for COVID. They're just coming back to the ER to be treated and seen. So, and the acute care, to a certain extent in September, seems to be rebounding from some pretty slow months in the past couple of months. So we're hopeful for that. And then the barcode scanning thing, I think we're going to talk about it for medication administration in the ER pretty soon for that. Ross pulled that off the consent agenda. But there's also some barcode scanning opportunities for supplies as well, to start capturing some of the lost charges that we see. So we may be doing some, because our CPSI system already does that. It's just a matter of now learning how to capture that and doing it real time at the bedside.
So we shouldn't be like just sticking the little stickers on your shirt.
Mark on
coat.
scan,
remember
remember,
that. Okay.
they deliver, and that's
Just-
probably the plan.
That used to be, you know, they were,
They used to call it
The
the
ones
chest
that you
neck.
see
Yeah.
That's right.
on the bottom of your shoe. and
right,
all
you're like,
sorts.
God knows what, oh, that was, yeah.
Right.
No, so those are some of the things, and we're trying to automate some of these systems and make lost charges or medication errors improve, and that's the goal. So anyway, that's my pitch. And that's it.
I have one other question. And you're talking about the COVID vaccine. The one thing, obviously, the state has done away with paying for any COVID vaccines now.
To the ER, 77 to the ER.
And- Yeah, right. And so apparently the county was able to get about 9,000 doses. Commercial rates apparently now for buying vaccine is about $200 a dose. It's really high. They were able to get some through the MicaVax. There was a bridge program. We didn't do that, did we? Okay, so there's a couple of facilities that the county is going to supply to. Kurt Medical, one of those, and some of their clinics, and so forth. But yeah, and the sense was, he said, you know, again, because of the costs now for that you're not gonna see anybody get vaccinated anymore, just because no one's gonna do it, you know. Just something that we need to watch out for, you know. Like I said, I think everybody now is just concerned, well, did it really do what we thought it was gonna do and stuff like this, but now that these things are so high priced, that may have a big impact on providers providing them anymore, so. Just.
So- But is healthcare, are we gonna make them mandatory for working? Is that something we're gonna?
No, because that was relaxed. We don't have to do that anymore.
Okay.
When the crisis went away, the requirement to mandate our employees to be vaccinated.
Because I've had COVID 4 times since my vaccination, so.
Obviously didn't work,
Don't waste your time.
but hopefully
Yeah.
it was a lesser case. I mean, that was what you hoped for.
Not all of them.
Yeah.
Yeah, so and I tested, but I didn't come to the ER, but if it'll help your numbers, I could. My husband and I
I'll
both,
just add you to the.
Okay. Daryl and I both. So I'm just kind of, because I know we have to mask up at work. So everybody's going back to that, but I don't know if we are here or not. So,
Again, and this was the conversation that we talked about, that the recommendation based on, that was primarily for the flu thing.
Yeah.
Our position with the employees is if we see enough of an increase in the community, then we reserve the right to ask employees to mask up.
because Clinica is
I know,
going back to mandated.
yeah, I think LA County is, because I had to go back to Cedar Sinai again for an appointment and I had to mask. I had to wear a mask. So
When I went to UCLA, the first visit I went there, mask everywhere in all their facilities. The next visit, the next week, nobody was wearing them.
And those are individual mandates. That's not.
Are those just facility mandates? not-
Facility mandates.
Okay,
Yeah.
gotcha.
Because latest AFL still, if it's a certain rate in your community, it's recommended. If it's a higher rate, it's strongly.
Strongly recommended.
But
So
that's
nothing's
latest
required.
AFL is.
Unless the facility, like I said, that's why we reserve that right.
Okay, that's, I was curious because I was off a week with it.
Yeah.
But I had to wear a mask when I returned, but then the same day I returned, everybody had to mask up.
Yeah,
Oh.
some of them are kind of taking stronger measures, not sure why. Unless they're seeing a higher positivity rate within their clinic practice or their employee issues or things like that.
How long do those masks last? Do we have a good supply that we can?
Oh, we still got plenty. Yeah.
They don't age out.
Good question, Greg.
They do have.
They do at time, yeah.
They do after time. They
Well, we're safe right now.
Well, and even the ones we got, because we got a mess from the county, and even the county came back and said, well, based upon the codes for the mat that are imprinted on the mask, they said, well, you know, we're good for so many years beyond the expiration dates on those things, and so And again, that, you know, they've come out and said, well, the masks really don't do any good and so forth. So it's hard to tell, you know, having one on versus not having one, I think is probably better than not.
They don't do good.
This is why it's been so frustrating. Yeah, well, people can still choose to do that, you know.
The only reason they get dated is for the elasticity.
In the band, right, not the mask itself.
And I can see that because I've had several of them just go boing.
Yes.
Yep,
And-
right,
yeah.
yeah. That's really where that expiration.
The actual fabric itself is.
Catherine, do you have any questions from work?
No, I'm done.
Gene?
No.
Mr. Elliott?
I do.
Yes, sir.
Mark, I'm glad you're applying for one of those current family grants. Because I think we need to
Support that as much as.
ride that as long as we
Yes,
can.
sir.
Because the longer we can prevent having to charge people for that service, the better. I think once we start charging for it,
You know, the other side of that is that, and Dave has commented on this too. If we're getting people to their appointments, we're gathering.
Revenue, right.
we're getting a benefit. from
A
that anyway.
benefit from that anyway. If I'm taking somebody to an appointment in Bakersfield, I'm not getting. it.
Right.
But anything with physical therapy, local, like even here, you know, to the hospital, it's a benefit to us. So that's why-
Strategically, even a trip to Bakersfield that we're not benefiting from financially. I'm hoping in their mind, they're thinking, but Kern Valley Healthcare is put me there.
You would be amazed at how many people don't appreciate what we're doing for them. But there are a lot of people who absolutely do, and that's why.
Some people are just ungrateful no matter what you do.
Yeah.
Just that's human nature, I guess. But yeah, it's still a worthwhile thing for us to do.
John?
I don't have anything.
Thank you, sir. Mr. Cooper.
Thank you, Fred. Before I get started, this is kind of a historic moment, and I'd be remiss in not mentioning Barbara Figueroa. She's here at this meeting. I can see she's retiring and going to be leaving us soon in the next couple of weeks, and I just wanted to honor her and let you guys know how important she's been to our organization. She's been here, what, since 1973, Barbara? Anyway, I'm going to miss her. She's done so much good work over the years and got us through so many tough times and has done a tremendous job. And I hope you all join me in taking this moment to give her some honor before I do my presentation. So anyway, I give you. Thank you, Barbara. I don't know, Barbara, do you want to say anything?
Watch, she's on.
No, thank you.
Barbara could write a whole book on the Kern Valley. If you wanted to.
So we're into fiscal 24, and the first month I'm going to jump right in here. Mark spent a lot of time on volumes. We're on page 17 of the packet. I'm just going to talk about the FTE part of this spreadsheet. We did a good job, even though skilled and inpatient was down a little bit. He's right, ER was good, but we did have lower revenues, but we also kept our productivity in good shape. You can see on line 44, 197.55 FTEs actual compared to the 205 budget. So about 8 FTEs less than budget. So we did do a good job in scaling down our staffing for the lesser volumes on the departments that were slower. I'm going to move on 2 pages to 19. And keep in mind when we talk about this financial strength index, this is the same formula that's been on the spreadsheet for many, many years. And a lot of you remember times when our numbers were closer to the 0 to 2 and maybe even below 0 sometimes. So these numbers that have continued to be going up is a reflection of consistent operating performance plus higher than normal in terms of our liquidity, and our cash balances have continued to far exceed industry standards. So we continue to show an amount in the excellent category of 4.23. Now, having said that, it'll probably go down back into the high threes, but it's projected to stay high the rest of this year and hopefully going forward. So we can be thankful that we have a strong organization in relative terms. When I think of the new news that Tim pointed out as far as the minimum wage, I'm firsthand aware of a lot of hospitals, district hospitals especially, who are right on the edge financially, not sitting like we are with our financial strength index, who once this is imposed on them, and the 16% increase, if we gave everyone with zero compression, if we kept it zero compression, that would be a 2.8 million per year hit to our bottom line, which, you know, the other organizations could not absorb that, neither could we. So if I was to guess, if the governor ends up signing this, it wouldn't surprise me that 6 months to a year from now, there'll be some major bailouts in terms of funding, additional funding for hospitals, because they won't have any choice, that these hospitals that are already on the edge just got pushed over and into a really distressed position. So that would possibly be more money for us as well if all the hospitals started, if they created a new program of funding to bail out hospitals, that, because it's clearly going to cause those hospitals to even be more at risk of failing. The next thing I want to talk about is the positive takeaways for the month. It was kind of a break-even month. I'd call it moderately slow in volumes. However, our operating expenses did make up for a lot of it at 5.7% lower than budget. I don't want to understate the importance of this number 2. Recent excellent news, we did finalize the IGT amounts for our rate range for this year, which has a tendency to then carry forward in following years. And the reallocation of the amounts that the plans have given to our district has caused an increase anywhere from 1.6 to 2.5 million projected increase over last year in terms of that particular program. Now not every other district hospital got that. We had the benefit of our receiving more allocation as a result of one district hospital to Hatchapee no longer being part of that program. So that's going to bode well for our future, and it's very encouraging that we are well positioned in the area of supplemental funding. We also feel better about our AR situation. Our collections were good in July and also even better in August. So I'm seeing that level itself out and look like it's really performing at a much better level of accounts receivable, including the coding and all the different areas of revenue cycle. The negative issues, we did have a little bit of a drop in cash, mostly because the supplemental funding doesn't happen the first couple of months of the new fiscal year. So that's a typical thing that we expect, is a drop in cash. We also didn't have the volumes in terms of gross charges hitting our budgeted numbers for the month of July. Looking at it from a graphic perspective, you can see this number right here in net income. So barely, I would call it a break-even month, a slight loss there. And you can see how it compares to the prior months. The 12 months before that had some really good months in here with the ERC program. One other thing to look at here is on the inpatient side. We had looking back at last summer, it was a pretty good finish of the quarter. Going into the fall, inpatient starts picking up. So, and we're starting to see that in the August and September numbers. Our numbers are starting to go up from the 84 that we had in its acute days in July. So that's kind of the trend that you can see with all that information. You can also see the confirmation of what I talked about for AR improving. You want lower the better. So I'm moving on to page 21, and on line 4, we see the gross patient accounts receivable figure fall fairly precipitously, over $1 million reduction, 1,277,000 down to 25,774,000. So we are seeing some improvement on accounts receivable.
Dave, real quick, maybe I asked this in finance, forgive me if I didn't, but the AR, does this include some of the aging AR that's been outstanding the last 3 years?
Yeah.
I know that was.
And that's where I feel that even the most positive is our percentages over 90 days, over 120 days, and over 180 days are all significantly less. It probably over since the last 5 years at our best levels in terms of the quality of the AR is all newer stuff. So that gives me confidence that we're in good shape to have those denials come down dramatically, because we don't have a lot of old stuff that's sitting out there. Thank you for that question. We do have one negative number that's higher that we're really going to work frantically to get that number down. We've over the last year and a half, Barbara's done a great job in having this number right at $1 million or a little bit below $1 million. 1.3 is a good number that we had in the last month. It went way up. So we have had about a month where we've had higher accounts payable. We're going to be working hard to get that number back down, especially as it relates to making sure key vendors like some of our construction vendors are taken care of, and we don't alienate or establish any kind of bad relationships with any of our construction vendors as we move forward into the new project, that we have to be extra sensitive to keep that AP number lower. We do have some issues going on with staffing. We've had our AP person out, so that's played a role in it. We also had some cash transferring issues that we've straightened out. So I'm not going to let that happen again. We shouldn't let it happen in the 1 month.
You're talking about construction workers. That grant that we're applying for FEMA, you can't have started the construction. You don't.
That's true.
No,
So
yeah,
that-
we're done with that. The emergency project, emergency generator project, it's making sure that they.
So we're not talking about construction workers.
No.
We obviously want as many contractors as possible to, when it comes time to put the whole thing out to bid, we don't want to have a bad reputation with those contractors. So that's an important part of our operations. The next page, our profit loss on page 23, and see a slight operating loss of 18,000. Line 28, operating expenses. Well, I don't know what I just hit, but got to get out of that. So I got to figure out how to.
Thursday afternoon, so it's double.
80 degrees in Beaumont, is that what it says?
Okay, so we were talking about the operating expenses on line 28, excuse me, 2,927,000, 163,000 below budget, or 5.29%. And that would have even been better, except some of the higher expenses in purchase services had to do with some construction and laundry and other areas that could have easily been capitalized on some of the expenses in purchase services.
Those can be adjusted.
Numbers. Yes. So I wanted to keep my report brief and keep in mind, if there's any real big significant financial news from my perspective, the 22 million, after talking to the consultants on this FEMA grant, this is pretty much, they have never had a client at this stage of approval with FEMA lose the funding. So we are pretty much in great shape and need to start planning and expecting to get this $23 million FEMA grant. So I think this is huge news for the district. And I always like to celebrate our successes. If we wait longer, because this will get dragged out, and then we finally actually get the final approval, we're all going to say, oh, well, we knew that this is old news. We shouldn't be happy. So I'm going to be happy right now about it, because I really think, based on the people that know the most about these kind of issues, that I think it's in the bag, and I think we should feel really good about this huge in-source of money coming into the district.
Hey, Dave, if the government shuts down because there's no budget approved, because Congress doesn't seem to be moving towards that, will that affect this FEMA grant? Will that delay it? Does that mean we don't get the money?
You know, I wondered about that too. I don't have an answer for you. I was going to call and start checking out, because FEMA is obviously part of the federal government.
I guess there would be no way to spend cash if we don't have an approved
There's no
budget.
staff. Yeah, we couldn't
Yeah.
get
So
any agreements or
I
anything.
think, I don't think it would cancel it. I think it would certainly delay
Just
stuff.
hold it back. Okay.
So yeah, that obviously could be a bigger delay, but as you know, eventually the federal government does get around to passing whatever is necessary to increase the debt limit.
Hopefully.
Like I said, forgive me for being the pessimist, but I'll celebrate when it's in the bank, okay?
Well, it's good that you bring the balance to the group here.
Yeah, it's one of those things where the amount of money for this particular year has already been set. That's what Dave was alluding to, is that the amount of ones that are just waiting for approval do not exceed the dollar amount that had already been set aside for this year for the grant program. And understand also that obviously if we do receive the grant, we still pay the invoices, and then we take the submitted invoices and send them to FEMA and they reimburse us.
Yeah.
Now, if we don't have.
Thank you for that, Bob.
to complete the project, are we required, how does that work? The money's for the project. We spend our money first or last? How does that work?
No, the way it works is they're paying 2/3, we're paying 1/3. Now, granted, okay, let's just say the first invoice comes in from the general contractor for $1 million. We pay the $1 million, we submit that to FEMA, they reimburse us 2/3 of $1 million.
They say 2/3 through, we run out of money. And we can't pay 1/3, do they still keep paying?
Well, we already have the money for our third in the bank.
So the issue is, the issue is,
Yes, we do. Yes, we do. We have our third of the money in the bank, ready to go if FEMA comes in with their 2/3.
but no, his question has to do with the fact that, again, because we've got multiple phases of this project, and so we actually have maybe more construction costs than we actually have money set aside at this point, even with the FEMA. And the point is, then what happens?
So if the project goes higher than what is expected, FEMA doesn't kick in any more money, we would have to kick in any additional monies. But currently, if the project bids out at where the consultants said it will bid out, we already have the money in fact.
I didn't know we had consultants. Real,
We
real.
remember.
So
we
just the
had consultants
repricing, yeah.
Put a price to this construction project.
Recost.
With a lot of conditions.
With a lot of conditions, but also increases for every year
Okay,
through the length of the project.
Yeah.
We had it professionally costed.
cool.
Gene, do you have any questions for Dave?
No, that, and I don't know if I broke in.
So I'm still thinking we just got an extra $23 million that we should be happy about.
As long as it's not
We're
the
gonna
last
spend it.
straw that goes camel's back. Puts us into something we can't pay out of.
The email will come to me, and I will obviously let everybody know the second I get that email that says you have been awarded.
Cool.
Catherine, you have anything for Dave?
I do not. Thank you, Dave.
Yeah.
No, I asked most of the questions at point.
Shelley?
No, thanks.
Thank you, Dave. All right, for old business, we have none. Under new business, we are tabling G1 at this time. Okay. And
Why are we tabling it? Is it a request or just?
My
I
request.
don't know.
Bottom line, I had not seen the data beforehand.
Okay.
And so I don't want anything coming here that I haven't seen. And I had a number of questions that came up on there that I want to weigh in on and so forth. So I want to make sure we're all good before we present it to you. I think in theory, there's some logic to it, you know, and but I have some concerns about decisions we'd have to make on long-term debt that we would place on the organization and so forth. So I just want to make sure we all understand it.
All right.
Well, yeah, and that was part of my concern at finance, was I didn't want to go through another county mortgage bond where I've got the facility and our cash back in collateral. I don't want to go.
Yeah, I don't either.
okay,
Worked so hard to get out.
MVHC recruitment. Mr. Davis.
You should all have a 2-page document. If anyone doesn't have one and they want, they have a few extra here, but it's some points that I'm using for my efforts on recruiting for clinical providers within the clinic. So, you know, the first item talks about what I'm actually looking for. We're looking for a family practitioner, a physician. We're looking for a full-time PA or nurse practitioner, and then an additional PA or nurse practitioner to not only work in the clinic, but also work on our population health, which is our QIP grant, which is very valuable, and working in the mobile clinic out in the community. You know, some of my things, a short list of the things that I look for in my candidates. I wanted to spend most of my time looking at what we have and what we, what some of our hurdles are, you know, our assets are. That it's interesting because all of our recruiters say that what we're offering for our physicians and PAs is, for the most part, is fair, but people are looking for more and people are getting more. So it's also listed down in our in the hurdles that I've seen. Our schedule for our providers is very, very attractive. It's the biggest attraction that we have. We have our providers work 3 12-hour shifts a week. We pay them for 40 hours a week. And, you know, the other 4 hours is for, you know, charting time, call time, calls that, you know, filling prescriptions while they're not actually in the office. So people love that. It's an affordable community. We offer a state loan repayment program. We're providers under National Health Service Corps. We have a really high HIPSA score. Not sure why, but for years, Ridgecrest has had a higher HIPSA score. HIPSA is a health provider shortage area, and that means a lot when you're applying for loan repayment. So anyway, we have those things, and those are very, very strong things that we have. Some of the hurdles that we have, the biggest hurdle is that there's just a primary care shortage, you know, in providers. I was on a call yesterday with, or 2 days ago with Kaiser, and down in Bakersfield, they're saying that they're seeing huge problems with both retention and recruitment. Rural locations, sometimes people just don't want to come to a rural environment, even though we explain that, hey, we're close to lots of things that you'd be looking for. They still think that we're on Mars, so that's a hard thing. The recruiters do a good job helping with that, but it's still a struggle.
And we want to use that new video that came out as a kind of a way.
I hope so.
Yeah, that's a great tool. I think that we can add to the program.
People that don't want to relocate, even into surrounding communities where they could easily drive, you know, every day. That's one of the problems. Rising salary expectations. My next thing is kind of a new thing. So a lot of specifically physicians in residency are looking for is kind of a new thing that's kind of spreading like wildfires, residency stipends. Residency stipend is, hey, I'm still in residency. I have a year and a half or 2 years to go, and I want to be paid every month, you know, kind of in advance. So, and unfortunately, you know, when I first heard it, I said, you got to be kidding me. But you know, now it's kind of spread to all of the residency programs. So a lot of people are really looking for that. And also like early sign-on bonuses would be the other, early sign-on bonuses are tough, and this is an area where Scott can help us possibly if we're looking at potentially residency stipends or sign-on bonuses. How can we have agreements that have more teeth in it, so they're actually enforceable?
Do you want to comment on some of the things we learned recently from our competitors in terms of things they're offering?
Yeah, we talked about it at a little bit down in, or a little bit at building and finance. Building and planning, sorry, where, you know, we're looking at local comparisons with other providers, and the salaries are higher than what we're offering right now. The sign-on bonuses are higher, including things like mortgage assistance. So when I first looked at mortgage assistance, scratched my head, well, what are we talking about here? But then when you think about it, offering someone some type of assistance in purchasing a house, it's going to be a lot, doesn't mean they won't leave, but it's going to make relocating a lot more difficult, or a lot more, it's a bigger thing keeping them in the community. So there's that, and higher sign-on bonuses. So we'll be looking, you know, Tim and I will be talking about that. I want to talk with Tim tomorrow about the current health systems grant and some of the bonuses and some things that I have in my ideas about enticing candidates.
And some of the things, like I said, I think like with the mortgage and stipend, things like that. Because again, what you can do is you can set, we're going to do it to a certain dollar limit. And I think they were doing 175,000 or 150,000 or something like that. But and you can set that, so it's great. It's $3,000 a month or $4,000 a month, as long as you're still here working. You know, so it's valued up to you hit that cutoff point. So, which is obviously an incentive to stay, and so forth. So, not necessarily as financially bad as it sounds. And you're not giving somebody $150,000, $170,000 and they walk out. So there's a lot of it depending upon how it's structured. And obviously, we'd have to work with Scott, and we decided to move forward with something like that.
Well, then, you know, that grant, at least the way I was reading it, they were looking for innovative ideas.
Yeah.
I'd sure not hold back.
That's what I told Greg. I said, shoot for the moon.
Yeah.
All I come back to, here's what we'll fund, you know,
Right.
but you don't ask, you don't get, so.
Looking at tools, you know, what we're already doing, we're posting on our current website. We have recruiters that are working with us. I have 3 that I'm actively working with. The grants, we talked about that, and I have some ideas about the grants. I have a call in to Dina at Current Health Systems, and we're going to set up a meeting hopefully after I can spend a little bit of time tomorrow talking. So in assistance and, you know, helping with what are they actually looking for, you know, how can we make this successful. Some candidates in the loop I have listed here. I have an offer out to a nurse practitioner. This candidate seems very positive. I'll probably know tomorrow. If I don't hear by tomorrow, then I'll follow up on Monday about this candidate. So that would be that one's the most pressing need I have right now. So the family practice physician, I have one who's most likely coming up on Thursday, and this one, it's a lot of my ideas for an ideal candidate. Doesn't meet all of them, but probably next week or the week after, this position will be coming up. We have another one who's you know, somewhat local, that has interest in working up here, but has a financial commitment where he's at right now. So we can spend some more time talking about that.
Does that mean he's looking for us to buy him out of that situation?
He hasn't asked, but it is a barrier.
And it's what I think would take.
Okay. Because of this one specifically, we couldn't use Current Health Systems as a funding source for that one. So my action plan, continue everything that I'm doing. Probably equally important to physician recruitment is physician and provider retention. So retention is really important right now. Right now, I think that we have, we have several solid providers. If I bring someone in at higher rates, we have to make sure that we aren't, that we're keeping that in thought for parity for our existing providers. So I submitted my proposal to Tim and Dave and Cassandra, so we're looking at that. So I want to finalize that up. Looking at different, augmented sign-on bonuses, obligations based on term, and looking at the grant. We're also looking at other ways that we can do advertising our positions. So I'm also included with that. We're looking at, Indeed, which is definitely a lot of people look at, and I actually don't have a position posted right now on the National Service Corps, but I may be doing that in the future too. So anyway, that's what I'm working on.
Any questions?
Yeah. First of all, thank you for bringing this to the board, and I'd asked you to do this and I didn't think it was going to be so comprehensive. So this is awesome. Thank you. I definitely agree. We should be making the openings on all the possible sites there are out there, so we don't get overlooked. So to the extent that we can, our HR staff can make that happen, that would be terrific. I wonder if the recruiters, do they go to the schools? Are they actually have a presence in the schools? Or if not, do they have recruitment days that we need to be participating in?
These aren't people that are in schools, actually, for like residents. Residents is where we do spend a lot of time looking, because residents are kind of attracted to the things that we can offer to them. So they're in various programs, and some residencies are as small as five candidates. Some of them are much larger, but especially Curative spends a lot of time looking at the residency programs, reaching out to them. I have a meeting with one of our primary recruiters next week and his supervisors. So I want to talk to them about what we're talking about shifting with our offer, and I think that's going to open up a whole lot more candidates. We have another month and a half window right now for 2024 graduates. So I'm hoping that with the things that we're going to be able to offer, we're going to be able to see more candidates coming through.
Okay. Well, this is just so important to a lot of the things that we want to accomplish, in terms of using our mobile van, help access by the community to our services. We don't have the providers, we can't do any of that. So this ends up being so critical, and financially, we can't bill for services if we're not providing them. So,
and the trickle down into ancillary services like lab,
absolutely,
imaging, physical therapy, and even ER.
Yeah. Thank you. So important. Appreciate it.
I had a question. A PA, and I don't know anything about what we're talking about. But a PA to me seems like it took some of the burden off a doctor. The active doctor, right? Is that sort of what it's about?
Beyond that,
Most of our visits in the clinic are performed by mid-level providers. Well, it used to be called mid-level providers, now
Purpose of
advanced practice providers.
being able to have them. Where did that come from? Where you just had doctors, I had never heard of a PA. When did that come into being? How long has it been?
Well, I've been a PA for 30 years.
Okay, so has it been 30 years? Could be 40 years. How long?
About 50 years.
Okay, so before that, now why don't we have something now? It takes the burden off of both of you. You know what I'm saying? Change the rules a little bit to give a little relief.
well, a lot of that's gotta be approved by the
I know, it's
medical board
gotta
and
be
all
done.
the
It
state and all
was done 50 years ago.
Those things have been looked at. I mean, obviously, like I said, they have been given more and more autonomy in their practices. There used to be that they, had to report directly oversight of a medical physician. That some of those have been relaxed substantially to allow them more independent practice with some kind of a retrospective or review and so forth. Nurse practitioners have gone through similar things and have gotten more ability to independently practice. So it's changing. I mean, obviously, because I think.
Well, it changed a little quicker. But
Yeah, no question. I agree with you.
Greg, you're a great PA, you're a great doctor, great organizer. You were wonderful for our clinic, so I wasn't picking on you or anything. I was just, the change isn't happening fast enough.
Well, I
So-
think, I'm sorry, I'm gonna interrupt, but
No.
I mean, when you have the physician and then you have the physician's assistant and the nurse practitioner, there's your three right there. So that's the third level that you're asking
Take some of
about.
the work completely out of those three that could be removed. There's gotta be some things that could be.
I don't know.
Okay, like I
And the
said,
reason I say that because they have 15 minutes and
I'm
if you keep
looking-
removing
I'm
certain
looking at
things.
logic, I don't know anything about.
Oh,
it. Like I
logic and
said,
reason have nothing to
like
do
I
with
said,
this.
Nothing, okay.
Right, but really, if you can't keep watering it down because they have, what do you have, 15 minutes a patient?
But you're gonna have to water down pretty soon. Nobody will be able to get any service. It's gotta
Well,
be changed.
That is an issue the industry has to work on.
yeah,
You're right.
yeah, and we can't even fill with RNs or looking for doctors now.
Use the standards.
No,
No.
I'm saying he's the
You
standard
figure out how to get more
Get
people
other
interested
people
in doing these
to
jobs.
be able to learn less, but still fit into the system.
Yeah.
But they would still have to know what they were doing.
Probably the biggest barrier we have specifically talking about physicians and PAs, nurse practitioners is the laws do not really require the type of oversight that a lot of the plans are requiring. Current health systems is one of them, and we're getting a lot of pressure from current health systems about, who's supervising this PA for pediatrics or basic primary care things, even though all PAs are trained. So that's not really required because of recent law changes for both PAs and nurse practitioners, but it's still pushed on us by the health plans because the health plans are being pressured by the state. So the state has said, yeah, we see expanded services, expanded responsibilities in the PAs and nurse practitioners, but they put pressure on the health plans put pressure on us, and that's why
That's good though, that they make sure.
is physician, because we still need to have a family practitioner serving as oversight.
Thank you so much.
Yeah, just got a couple quick things. Thank you for putting this together, Greg. I concur. It's really good information and I'm happy that the three that are in the loop, none of them have said no. So that's promising. I thought at the building and planning meeting, I thought Gene and Ross brought up some pretty valid points with relation to like the school district, for example, and the mobile clinic. Like bringing the mobile clinic back to the school district perhaps, or like what we're trying to do with the VA, taking the mobile clinic to the VFW so the veterans can get their services. I guess my question is, I think I forwarded you some information on that School and Health Alliance. I know it was really long, but
Yeah.
Have we ever in the past done like a third party arrangement where, say, for example, like another healthcare or service provider comes in, utilizes our equipment or something because we don't have the staff and they go and do work like at the school district, for example, or.
This is what I was talking about with the thing that we're trying to do with Clinica and with Good Sam Hospital.
Okay.
For the psyche behavioral health stuff.
Oh, on the
Trying to do something between the three organizations.
Okay.
To provide a service that we can't provide or don't have the staff to provide, they do. And are anxious to expand those services. So, yeah, that's we're trying to do that. And this is one of the things that current health systems and a number of the health plans as part of their Cal Ames program is pushing very hard and willing to finance. Because the whole point, again, gets back to the access and how can we be creative in putting these multi-partnerships together to bring services to communities. That's exactly what this is all about. So,
and some of those grants can do things like, for example, like the mobile clinic, for example, that utilizing that to give services to the kids at the school or
But like I said, we've been lucky because we've been able to get two health plans to approve us to do that. Even if they weren't our patients, they'll still pay us for it.
I mean,
treating
obviously,
medical schools.
obviously, it's more advantageous for us as a healthcare district to have it done in-house,
Right.
of course, but,
Sometimes you can't do it all, so.
yeah.
That's why.
And then also on the grants, the stipends, can you use some of the grants to do the stipends to get them to stay here? Okay,
We can
I'm glad-
propose it anyway.
yeah,
But
absolutely.
they have done it in the past. I'll tell you that.
Okay, one, that's really good news. I'm happy that we made a lot of progress in just the last couple weeks, actually, since it all got passed.
Now, we talked a little bit about AI too. They've got equipment that will diagnose for a doctor. That should free up a lot of the time for the doctor. Now, it's expensive. Maybe it's too expensive for us, which is a pretty good sized grant. You weren't here.
I was here when you
Grant
talked several
for
years
AI.
ago about getting more into AI
Right.
and I think my response at the time was, this is really developing. I think you're seeing it now at a fever pitch that it's coming out there, and the big concern
Sometimes
from
pretty
my
expensive,
perspective
but we
is
could get a
control.
grant.
Who's gonna guide this thing and oversee its development and stuff like that. I think it has tremendous potential, you know, to assist in things. I mean, I was just reading an article the other day about its ability to predict cancer much earlier than we can do now. So it's pretty amazing what it can do.
Just for an everyday visit, it can diagnose, it can do everything that the doctor's the last thing,
Yeah.
just like the PA or nurse practitioner, but we need stuff
Yeah.
like that, equipment to be able to move forward, because that seems to be the way it's going.
Well, and again, I think a lot of it, like I said, as you talk about the manpower resource issues, I think you're getting to a point where the technology is going to take over to the point where it can do a bunch of the work, but you still need that hands-on practitioner to make those rational.
But it's an
decisions,
assistant, it's
you know.
another assistant, just like I was saying.
Exactly.
We need some help.
Yeah.
And, if that grant's out there, we should, I mean,
It kind of sounds like that '60s cartoon, the Jetsons. They weren't really that far off on a lot of their predictions.
you know,
That's
thank
Star
you.
Trek.
Yeah, thanks, Ray, for putting this together.
What do you want at the next meeting? Said, prosecute.
Or you just want to periodically report.
Still want me to report every month? I'm happy to do that.
I don't want you to have to come back if nothing's changed. But I would like to keep this in the forefront, so. I would like to see it next month, and if nothing's changed then, maybe we change the interval, but I'd like to keep it in front of the board.
Want to keep focus on it for us, and like I said, obviously, we'd love to be able to report some successes next time.
Yeah.
So hopefully, so.
If it's okay with you guys, if it's on the agenda.
Bob stepped down. But JTS change order was proposal number 5.
It's just the matter, we talked about it, building and planning, but it wasn't on the agenda, so that we couldn't.
Yeah, this was the addition, I believe, of some additional conduit.
To make
that,
a motion, we accepted it.
yeah, 20%.
I'll second.
All in favor?
Aye.
Aye. Public comment. Sorry, public comment. Public comment?
Is there any public
comment? Sorry, forgive me. Thank you, Scott. Is there any public comment? Yes, maybe? All right,
Everybody, let's hope it.
we're all looking.
I have a comment about everything.
All right.
Yeah, because I don't know what JTS is, so I can't comment.
No problem. Number 4, this one is from you, Dave.
Oh, wait, we have to vote.
We did.
Yeah.
Yeah, he said first.
We motioned and seconded, but.
Then we all said aye.
Oh,
And
and
he reminded me that I.
I'm an aye too.
I tried to jump in before the vote, but I
Okay.
didn't quite make it. Sorry.
Okay, we have a proposal, a revised proposal from Whipley to do our cost report. We did make the modification as requested in finance to take out the part where they wanted to have IT access to our system. And I think that's on the bottom of page 71 of your packet is no longer that clause has been taken out. So we're presenting this for approval. to move forward with Flea for another year of doing our cost report.
Make a motion.
Public comment first.
Oh, do you get public comment? Well,
No,
how do you
I got
you
that.
wanna make a motion?
You can make a motion, I'll accept it.
Okay, I make a motion, you can ask the public.
All right. If there's any public comment on this before we vote on it,
I have a question.
sir,
So the total amount is right around $40,000, probably exceed that with expenses that come up. How is that compared to last year's cost?
Yeah, good question. I brought it up at finance. It's a little bit of a sticker shock for me. Anywhere from, was it like 8 to 12% each of these line items that they increased. So it's more than what I would have normally expected. There's so few providers that work with cost reports for hospitals like us. I'm thinking, if they continue to get as expensive as we're seeing here, I probably need to start putting it out to bid. But it is,
Well, maybe they weren't charging enough before because they've been pretty good to us.
yeah, exactly.
it's extremely important financially to get a good auditor that CPAs that do these cost reports, because being cost-based on both skilled nursing and on the inpatient side really makes a difference, making sure that we get credit for everything that we deserve.
I had a question, Dave. For a long time, we always used to use Paul Faylot, Pacific Hospital Management out of San Francisco. At one point, he was kind of the acting CFO here. I know he is retired, but I could have thought that his son took over his cost report practice. I don't know for sure, but maybe that might be something to look into down the road.
Yeah, that would be something I'd be willing to look into.
Okay.
Maybe next year we start shopping around. Cause it's getting to be pretty big dollar.
Yeah, I agree. I'm not happy with that.
Gene, you still want to stick with your motion?
I'm fine, yes.
Second,
I'll second.
all in favor?
I,
Aye. Okay. Mr. Elliott, number 5 is for you.
I had a question on the barcode scanner proposal. Looking at the monthly cost, the capital improvement price is a one-time $15,000. And then if you look at the monthly cost, it's $14,255 annually. So it's almost as much to purchase the thing, and then you're paying the same amount monthly.
You have a license.
Is there a cheaper way to do this? Is this something that we really need? Is it worth the cost? I've wondered, and have we budgeted for this? Can we afford this?
So we have had several recommendations from our board committee regarding the barcode scanning option. I've avoided it for several years. T-System is our electronic health record for the ER. This is a T-System product that they've had it for things. We see several medication errors at our MERC committee meeting that could have been avoided if we'd had barcode scanning. This is also going to force the physicians to write real-time orders, which is opposed to verbal orders and things like that, because you have to have an order to scan a barcode. And so this is a way of forcing a couple of things to happen. The the MERC committee has recommended it. That's why I went with it. It was not on our capital budget request. But I think that going forward, the age that we live in and the digitization of all of these products, it's coming to fruition, whether it's expensive like this or we find some other option. I think barcode scanning is going to save us money. I mentioned it in my report where we're going to start barcode scanning for supplies that we
cover more lost charges and things like that.
Can
So
we do that for the same cost, or will it be an additional cost if it's scanned?
the barcode scanning for supplies,
Yeah.
no extra cost. It's already in our CPSI budget. So we already have that. I don't have to do anything except training with the staff on point of care. With the ER, nobody knows if it's going to pay for itself because there hasn't been a detrimental net error that has ever been created. And so, but it could happen one time.
Sure, yeah.
And so this is to prevent that. And it's prevented many errors. We've been doing it on MedSurg for years now. About 6 years, we're at about a 95% barcode scanning success rate. So we've avoided several medication errors because we've been able to profile the medication and dispense that and get the right patient, right time, right route, right drug, and all those things that we often look for. That when you're moving around in our setting, can be sometimes set aside and skip details. And so I think it's an important enough to kind of spend this money.
It's just, and again, it's not just, I think, from the recommendation from our MERP, I think what we've seen in the research by SNP and some of the other things that this has become an industry standard to move to barcoding wherever we can, just because of the better accountability, you know, for making sure you got the right patient, the right drug.
Well, if we can reduce errors, that's wonderful.
Yeah.
It just comes with a high price tag and Dave, can we pay for this? This is gonna be an additional expense to the ER every month.
Yes, we did add some, we did add some in the budget. It's close to, we have enough in there, but you're right, it's a strain on us financially. But it's one of those things that moving us into the 21st century for IT and being more up to date and to be more what the state of the art is in terms of what other facilities. Pretty much everyone else is already gone to barcoding.
All right,
So
thank you.
Make a motion, we accept the, or put it back, or approve it. It was not a consent. So what is it now? Do we need?
I
a
have
motion?
To make a motion.
Okay, I'd like to make a motion to accept it.
Second. Then go to
I'll second.
second, John. Public comment?
It's industry standard, and also maybe we can report what lost supplies. Maybe a comeback against that expense could be a lot of lost supplies and things.
This particular item does not cover supplies. We already have that. I just want to make sure that that's.
All right. All in favor?
Aye,
Aye. Okay. All right.
we can't break back out now anyway. We're sitting here.
After Terry said it doesn't cover supplies, I'm withdrawing my book on.
We already have.
All right, moving on, director's comments. Circle?
Probably I could direct any question rather than comment. The seating arrangement here, you've got me on the same side of the class. You got me sitting directly next to a lawyer.
Yeah.
I mean,
It's a
did I do-
nightmare.
what did I do wrong?
Nothing yet.
The only thing we could have done better was to have you between them.
No comment. Thank you.
It's Catherine.
Get here first and then see who sits next to you. That just, I think. No, lots of information, which I really appreciate. I was really lost with Greg because I got 2 back pages. But I was like, what?
Somebody's got two brothers.
But, you know, I thought, okay, and he's in charge of hiring somebody. I'm just kidding, but thank you very much. But just lots of information and, I really appreciate it because as much as I would like to think this stuff's not on my mind all the time, it really is. And, I'm just kind of curious, kind of off topic is how we're doing with the building on the boulevard. And we didn't discuss that today, right? Unless I missed it.
Bob?
Well, we can't discuss it, can we?
Okay, well,
Just recommendations.
the plans are in plan review at the county for suites B and C. And we're working on the other three. Got it all cleaned up outside down there as far as the parking lot. It's moving ahead, but I don't know how soon the county will have.
Yeah, and I
Okay.
guess was focusing on the outside of the building at the time.
Yeah, it's been cleaned.
Yeah, the weeds have been taken down and stuff, because I've walked it a couple times.
We still got some cobwebs.
It does look better, but yeah, there's still, I would think, but I don't know if that's something you guys do, if that's a company that we have that comes do it every once in a while.
Look at that.
Because then with the cobwebs and stuff, and I only noticed because, okay, well, it's the building that I noticed on, because that's only because of my husband and the things he does, I points out,
I'll take
but,
a look at it.
okay, yeah, but it looks so much better with just the weeds gone.
Sure.
And I think that's important. As Ross is always wanting a writer, I think our presentation of how our buildings look is, it's right there too.
The next building planning, you're gonna have a presentation from me on sourcing some of our grounds work, because we can't keep up.
Okay.
If we get through me, so.
Yeah.
Yeah, that's one I requested. It just, like I said, the appearance of our grounds is indicative of the quality and our caring for our presentation to the community. And so that's vital to me that, again, that we stay on top of that stuff. And
Not that they
say we've
even
had lots
know.
of rain and all this other stuff, but the bottom line, we still have to take
Yeah,
care of
not that the community even knows it's our building at the moment,
it.
but
It's our
I do,
pride and-
yeah, so, all right,
Yeah,
thank you.
We're
I'm
gonna,
out of-
as we're adding properties and stuff, it's becoming more than we can deal with existing staff, so. I'm already working on a presentation for additional.
All right, thank you.
Can I, what she did, Barbara has her own place picked out in that building. She did it when we first bought it. Are we gonna be able to get it finished before she retires? Or can she take it with her?
That's a definite no.
He's welcome to come back anytime.
Just a couple
I have a
things.
question about those plans, though. The ones that are in review, are those the ones that you sent to me last time, Bob?
For B and C, yes, and I know you had some questions, but I've been too busy to answer them.
The size of the billing area got reduced.
I think so.
No.
Can we talk about that one later?
Yeah, we'll talk to them. Yeah, and then we'll bring it back.
We need to sit down and go over it.
Yeah.
Thank you.
Thank you.
So again, I want to congratulate everybody for the patient safety honor roll designation. I think that's fabulous. I know that the times I've been here as a patient, I've been so impressed with the care I've received, the quality of care. So I'm not surprised at all that we got recognized for it, but I think the community needs to know that.
For sure.
We need to get out the horns and toot them. Barbara, I just want to say thank you. Thank you for your years of service. You've done an amazing job for us. I fear you being gone. I know that the people that fill your shoes are coming in behind you. I'm sure will end up doing a fine job, but you've done such great service for this district over the years, and I'm indebted to you and for your service. Thank you so much. I'd give you a big hug, but you probably don't want that anyway. So
Thank you.
thank you. Thank you so much. There was one other thing I want to talk about, but I don't see it in my notes, so I will shut up for now.
Got it. John?
Yeah, a couple of things. To reiterate Ross's point, that's great news about the patient safety designation. I agree, it should be, you know, to relate to the community, for sure. Greg, I appreciate you putting this together. This is a really good action plan, moving forward on the recruitment and retention efforts at the clinic and utilizing our mobile care vehicle. Also, Barbara, I want to take a moment to thank you, you know, for all your years of service. I remember coming to my first finance meeting when I was like, you want to pick on me, like 12 years old, my first run for public office for this seat. But no, that's how I got to know you. Of course, I knew your son Michael for many years, but I know you're going to enjoy a retirement with Frank and seeing your kids and grandkids. So that's important. And just thank you for all your years of service here at the accounting department at the hospital. Also wanted to mention Charlie Bush's memorial services on Saturday. He was on this board for many, many years. That's the same day as the Crab Fest. I'll try to make it, but it would be good to have some hospital presence there for all of his years that he served on this board. And then finally, the video that Chuck Barbie, he was my first boss in the film industry, actually. But that video that you and Ross participated in, I thought it was really well done. I know Ross talked about the healthcare district, and what I also liked about the video that he did was he addressed a lot of the issues that we have valley-wide, you know, and opportunities and the economy, just everything. It was a really well done video. I really enjoyed it. And so thank you for both of you for
Kudos to the Art Association.
and the Art Association. Yeah.
That's their project.
So now you both are film actors. So you're going to join the Screen Actors? They're still on strike. That's all I had.
All of you covered everything that I wanted to say, except Barbara. Enjoy the next chapter. With that said,
Thank you.
Let's go to closed session.
Yeah, so in closed session, the board did not discuss the Benson Lau or Wakava existing litigation matters. The board did hear the Medical Quality Council report, and no other items were discussed.
We're adjourned. Have a great day. Please stay safe. All right.